Good morning. I'm Carl Svedberg from Gothenburg, Sweden, and this is EHJ Today. We are at the ESC Congress in Rome, and with me today I have David Fitchett from Toronto, and who will present some data from the EMPA-REG outcome study, and to discuss the results we have Silvio Inzucchi from Yale. So welcome, and now David, the EMPA-REG study published a year ago really came with astonishing results. So then you have published more details, and earlier this year we had a paper on more details on on heart failure. So what have you what really was the EMPA-REG study main finding, and in relation also to the heart failure?
Thank you, Dr. Svedberg. The EMPA-REG study was a cardiovascular safety study looking at the impact of empagliflozin in patients with diabetes who are at high risk of developing heart problems. It included patients who had established cardiovascular disease and diabetes. The study was the first study of a glucose-lowering drug to show cardiovascular benefit. The 14% reduction of the combined endpoint, but most importantly, a 38% reduction in cardiovascular mortality. In addition to that, we showed that there was a 35% reduction in adjudicated hospitalization for heart failure. And it's part of this analysis that we wish to expand, and this is the basis of the presentation which I'll be making later on today.
Okay, what did you find?
Well, what we looked at was both adjudicated and non-adjudicated outcomes in heart failure. And the adjudicated outcome was hospitalization for heart failure. The non-adjudicated outcomes were investigator-reported heart failure and new use of diuretics. So we had these endpoints to look at, and we showed that empagliflozin reduced these events altogether, and when we summed them up, there was a clear reduction of these cardiovascular heart failure events. We then went on to look at the impact on mortality in these adjudicated and non-adjudicated, and there we included patients who had heart failure, prevalent heart failure at baseline, in addition to the adjudicated heart failure hospitalization and investigator-reported heart failure. And we grouped those three together, and we called that patients with a heart failure burden. And what we showed is that these patients with a heart failure burden had a very high cardiovascular mortality, and this was substantially reduced by empagliflozin to the extent that there was a 5% absolute risk reduction in this population. However, the patients who didn't have a heart failure burden had exactly the same relative risk reduction as the patients with a heart failure burden. So what this study shows is that patients with a heart failure burden have a special benefit, but patients who don't have a heart failure burden have a similar risk reduction. So the empagliflozin is applicable to patients who have a heart failure risk and patients who don't have a heart failure risk.
Okay, very interesting and important. So in summary, the new analysis seems to support the what you have seen before, but gives more flavor to it, so to say.
Correct. I think it gives strength to the initial analysis. And I think it widens the application of the drug as well. And it gives also some support to the ongoing trials, which will be looking at empagliflozin in patients with and without diabetes and with heart failure and preserved ejection fraction and reduced ejection fraction.
Now, from a diabetologist point of view, Silvio, how do you interpret the implications of these findings?
Well, I think the implications are profound. We all know that heart failure is an increasingly important outcome in patients with diabetes. In fact, some investigators have proposed that a new MACE event be constructed that includes heart failure outcomes. And as you know, the treatments for diabetes sometimes exacerbate the incidence of heart failure hospitalization. The TZDs come to mind, and in one of the DPP-4 inhibitor trials there was a slight increase in heart failure hospitalization. So obviously selecting drugs, because we have so many medications to choose from nowadays, selecting drugs that, if anything, reduce heart failure outcomes is critically important. One of the concerns with EMPA-REG is that because of its mechanism of action, it having a mild diuretic effect, that some have proposed that the sole reason for the decrease in cardiovascular overall outcomes was because of this heart failure group. And while there is substantial benefit in that group, I think one of the most important outcomes is that even in those patients who don't have heart failure at baseline, who never develop heart failure during the study, still appear to enjoy a benefit.
Yeah, it's interesting. Of course, it's been fascinating to see the effects on heart failure and how rapid it appeared in the study. So asking both of you, David first maybe, how do you explain these effects?
Well, EMPA-REG outcomes was not a mechanistic study, so we have to use a certain amount of speculation to know how the agent worked. However, I think we know what it didn't do. We don't think it worked through an atherosclerotic mechanism, for example, and probably reduction of blood pressure would be too fast an event, and an effect on diabetes, on A1C, is probably unlikely. However, I think that the fluid shifts, and remember that SGLT2 inhibitors also increase sodium excretion as well as causing an osmotic diuresis with glucose. And I think this reduction of plasma volume, which is well documented with SGLT2 inhibitors, may well be an important part of the mechanism.
Silvio, is there any direct effect on the metabolism, so to say, from this agent?
Yes, I was going to say that there are two prevailing hypotheses. One is the hemodynamic effect that David alluded to. The second is that these drugs do change metabolism beyond the effects on glucose. There's an increase in fat oxidation. There's also a slight increase in beta-hydroxybutyrate, a ketone body, and some have proposed that ketones may be a more efficient energy source, particularly for a dysfunctional ventricle. So there are two opposing views, that this is not just a reduction in blood volume, hemodynamic effect, but potentially some change in metabolic factors that affect the efficiency of cardiac function.
From a clinical point of view, how do you interpret these findings and how it's going to affect practice?
Well, we all feel, at least in the diabetes community, that the basic treatment for type 2 diabetes should be lifestyle, diet, increase in activity level, reduction in body weight. Beyond that, metformin remains the prevailing foundation treatment for patients who need glucose reduction in type 2 diabetes. The controversy comes, what next? Many patients cannot achieve hemoglobin A1C targets just with metformin. And as mentioned before, there are a wide variety of agents that can be used in combination with metformin, such as sulfonylureas, insulin, the incretin-based therapies. So now the SGLT2 inhibitors are clearly an option after metformin, and they may be potentially favored in those with prevalent cardiovascular disease, particularly those with heart failure.
Yeah, your findings, David, have also implicated, as Silvio alluded to, that we need to include heart failure more in the endpoints in diabetes trials. So what's your plans or what you think is going to happen, and now what's the next step in this? story?
I think the EMPA-REG outcomes trial was not a heart failure trial. Neither did we include patients with heart failure specifically, but we didn't measure outcomes in terms of heart function. We didn't have BNP measurements. So I think there is need for studies in patients with heart failure, and both preserved and reduced ejection fraction, to see whether these agents actually do benefit patients specifically with heart failure. So those are going to be ongoing starting towards the end of the year, and I think that those are very important to see whether these agents are going to be beneficial specifically in patients with established heart failure.
Okay, thank you. Very interesting, and congratulations to your study, which will certainly have implications for clinical practice. Thank you both.